and all of our sessions are recorded on our YouTube channel. And we also have a page on Mighty Networks where we also include resources discussed in these sessions. My name is Wes, and I'm one of the communications chairs. And each month we host a networking session around different topics. And this month we have Dr. G. Bai. Let's see, sorry. Dr. Bai is a professor of accounting at Johns Hopkins Carey Business School and professor of health policy and management at Johns Hopkins Bloomberg School of Public Health. An expert on healthcare accounting, finance, and policy, Dr. Bai has testified before House Ways and Means Committee, written for the Wall Street Journal and the Washington Post, and published her studies in leading academic journals such as the New England Journal of Medicine, JAMA, and Health Affairs. Her work has been widely featured in the media and used in government regulations and congressional testimonies. Dr. Bai has received the Johns Hopkins Alumni Association's Excellence in Teaching Award. She was a visiting scholar at the Health Analysis Division of the Congressional Budget Office from 2022 to 2023. And Dr. Bai regularly writes for Forbes. So without further ado, I'll pass it along to you, Dr.
Thank you so much, Wes, and thank you everybody for first of all having me. This is really a huge honor, for me to be able to talk to so many people using this platform. It's really a privilege. And then especially out of Hopkins little realm. So really appreciate your time and giving me the opportunity. So let me share my slides. So we are gonna first of all, I'm an accountant. I teach accounting, as Wes introduced me. So my focus is really about money. So I have no clinical training. And I ran into healthcare pure by accident. When I was a doctoral student, my dissertation is about governance, board governance. And where do I get the data? Or the only place have that, to my knowledge at that time, that have very comprehensive board trustee data is actually hospitals. So that's how I ran into healthcare. And then until today, so please bear with me if I'm too much focused on monetary side of healthcare. Right. Okay, so today I'm sharing my humble view on affordable care, equal access, and better health. Again, from a monetary perspective. So we have 5 things to cover. So I'm going to first talk about fundamental monetary rules, and then especially applicable to healthcare. Then we talk about the evidence on price, access, health, and then we think about what's the problem, who to blame, and then who should take more control. And then finally, we talk about, in my opinion, what should we move toward in order to reach equal access, better health, and affordable price. Okay, so great. So Wes, is this format go as people will ask questions or everybody wait in the end?
Oh, we can, normally we'll do it at the end. People will either ask out loud or type in the chat.
All right, great, thank you. But if you have some urgent question regarding some content, feel free to interrupt me. That's totally fine. Thank you. So there are 5 rules, in my opinion, for the past more than decade research in healthcare finance. I think there are, let me just share with you. Rule number 1, everybody wants wealth and health, right? So this pursuit of money is a common goal among all the players. We heard about greed, right? Private equity, we heard about hospitals and insurance companies. So everybody is pursuing money, so all the players. And that is universal. But also, if we think about, how is money made? In general, right? If the first paragraph of the Wealth of Nations says the wealth is created by labor, by effort, right? Why do we exert effort? Because we want the money, right? This greed is a fundamental driver of our society. So that's how it's money made, because we want the wealth. In order to pursue wealth, we also want a house. But then once we get a wealth, we want a health. So it's combined. This pursuit of money and health push us forward. Then how's money spent? We spend money always contributing back to economy. So in my MBA teaching, I first lay out this making money is universal, and when you spend money, you contribute back to society. So making money itself is not bad. is actually contributing to our economy. Sorry, John. Then how's human capital accumulated? Like when I teach MBA students, they came to our program making probably $50,000 or $60,000 a year. After graduate, they were aiming to get more than 120, right? That's what they hope. So in human capital accumulated through effort. So you do things, you learn things, you accumulate capital. So that is the fundamental thing I believe will contribute to both the wealth and health. That's why in the US, richer people live longer. That's just a fact, not just in the US, everywhere, right? So you have, because they accumulate some kind of human capital, they can use it for both wealth accumulation as well as health accumulation. And finally, how is societal wealth built? By people who have health and who pursue wealth. Okay, so that's rule number one. We all want money and health, and that's why we have here a discussion, about healthcare finance. So rule number two, nobody cares when spending other people's money. So I put here, on the right, on the slide. I know we're gonna share the slide, so I put the link to my writing or some studies, so you can go there for more details. Let's say, I'm going to have an opportunity to pay $5 or $6 a month to get an Uber discount. So every time I take Uber, will give me the 10%. I forgot the detail, but there's a kind of Uber discount I pay a month and then give me savings. Let's say I use Uber all the time. Now consider you're gonna pay the $5 or $6 a month but from your own personal account. Assuming your Uber transportation fees completely covered by your employer, everything reimbursed. I'm an important person for my company reimbursed my Uber. Would you pay $5 or $6 each month from your own pocket for this Uber discount program? Absolutely not, right? Because I'm using other people's money. Why should I care? 100% reimbursed. But imagine if you are you're just self-employed person, every Uber trip is paid by yourself, and you use this all the time, every day. Would you pay $5? I would say absolutely yes, because I use it every day. So that tells us really, it's not about morality. It's not about who's good or so societal oriented. We simply do not care when we spend other people's money. If you have children, you know this. You give them allowance, what's it? They just ask you for money. It's totally different. Then why do I bring this? Come back to comparison shopping.
It could be maybe black and white, but
then come back to the comparison shopping. We all know there's a push for healthcare price transparency. I'm a little bit concerned about its immediate utilization unless we have skin in the game. Like if everything the healthcare spending comes from a third party, not from our pocket, why should we care? Weird. Like for myself, if I'm going to get an X-ray, $20, just make it up, versus a MRI, $5,000, assuming there's no really impact on like the accuracy, just make it up. I would not care if it's $20 saving, like $20 versus $5,000. I'm going to use whatever, is there and looks good or worse. In other words, I will not worry about the price if I do not pay. Okay, so that's the rule number two that governs all our behavior in healthcare. Nobody cares when spending other people's money. And then rule number three is make whoever controls revenue happy. Sorry, so this, I should not put the box here. Sorry about that. So this is the most recent 2023 leading lobbying industry spending for United States. So if you can you see it? Oops. The top, what's the top one? I hope you can see that. It's a pharmaceutical, right? Pharmaceutical and health products. And there's everything in millions. So it's almost $380 million. And then you have insurance. You know what? Among this $157 million, the insurance, a lot of majority is actually health insurance, not life automobile insurance. And if you go lower, there's it's a hospital. I put the link there. I think somewhere it's a hospital. And then we have healthcare professionals, and sorry, hospitals here. So 131. So you see among the top ones, if you link, you might say, oh, maybe defense or other things are actually top. No, it's really about our healthcare industry. And then why? Why do they lobby so much? Because their revenue pretty much controlled by government policy, right? So you got to make whoever control revenue happy, period. If my money comes to my boss, I'm going to do whatever my boss asks me to do. If my money comes from the consumers, I have to make consumers happy. Otherwise, they don't give me money. But if my money comes from government, I just have to lobby. That's the only way. Again, it's not about morality. It's about the revenue source. We know that during COVID, right? Our COVID like at-home test, the free test. If we buy online, initially it's about $25. At that time in Europe, we can buy it at 1 or 2 euros. Same test, COVID at-home test. But you might ask why? Well, in the US, we only have 3 vendors, and then they are all somehow connected with FDA folks who actually approve those tests. Then you would be dumb if you do not try to get that position, right? You want to be one of the 3, one of the 4. Then basically you don't have any competitors. They're all excluded from the ability to provide at-home tests. So that's the reason, we're gonna see more and more lobbying, simply because more and more providers, more and more players gonna recognize government has so much control in healthcare revenue. So for them, it's revenue, right? So they have to put more investment into making whoever design the rules happy, okay, instead of patients. Extreme case would be Medicaid. I know many of our audience really care about Medicaid. Think about Medicaid patients. What kind of power do they have? They have no power. They do whatever they're being assigned to. If they're not happy, let it be, right? They have no power. So, but then whoever designed the Medicaid policy have power. So that's why we have a lot of lobbying also going at the state and federal level for the Medicaid policies. Okay, that's number 3. Number 4. So market transactions make every party better off. So in market transactions, this is not just for healthcare, it's fundamentally everywhere. There's no coercion, right? It's voluntary transaction. You pay, and then the seller, so you pay the money, and get the service or products, and the seller provided. So in this exchange, there's no involuntarily. So they will make both parties better off. And then it gives a valuation too. So let's say I said I just graduated from MBA. I'm amazing. I should get paid $500,000. But that's only your subjective valuation, right? So your market value, how much is your labor cost? You have to value this through a market, through collective wisdom, because people are bidding for you and you are competing with other people, right? Together we have valuation. So that's the second rule of market. And the third is capital allocation. So people know, everybody trying to make most money, so they channel their money to the best way. Let's say AI is hot, everybody put money into AI without any government coercion or government guidance. They will do that. So imagine non-Medicaid patients have the same amount of money. They just got a card, for example. They have money, $20,000, for example. They can buy things. Do you believe that a provider will say, because you're a Medicaid patient, I won't see you? I'm a great physician. I charge the let's say pretty high price, but if you pay, I'm gonna see you, right? Unless they're really dumb, they want to make money, so they are going to voluntarily provide a service to whoever pays. That's a fundamental rule of market transaction. Okay, next one. So policymakers have imperfect information incentives. So in policymaking, we have limited knowledge, right? Even if like all of us, we have a committee, we discuss, etc. We're still only 30, 40 people. We have limited knowledge of what's right now happening and what will happen. Okay, that is fundamental truth. We just have limited number of people. Will have less information than the wide, broad market. So that's what I meant by this imperfect information. So recently I wrote an article on Forbes. Should Medicaid give patient air conditioning or cash? So in Oregon, so the Medicaid program got this money and then they bought air conditioning, air filters, heaters, and sent that to Medicaid patients. Then the question is, do you really think that same amount of money will help patients as much as within two options, giving them air conditioning or give them cash? So that's a question I ask. Because of this imperfect information, sometimes we will have short-term focus from policymakers. Okay, I give you air conditioning, this is good right now, but then there's long-term waste. For example, Oregon, maybe this year is not that hot, right? Maybe for the next 3 years not that hot. So the patient don't have the control of that money for the things they want. For example, they might need healthy food, or they might need a safer neighborhood to live. So they do not have the chance to use that money to put in the purposes that they think will help their health most. Therefore, I said here, there's a short-term focus from policymakers, but there's a long-term understanding from actual players in the market. And then sometimes that can lead to a lot of unaccountability. I also wrote an article recently on banning medical debt from credit reports. Let's come back to the same point. Government wanna say we don't want you to we don't want the credit reporting agency to include medical debt. But then the problem is, in the long run, that will actually hurt the patient. Hospitals will not let patients to get care in advance. You have to pay, right? That limits the ability for low-income patients to access care. And then credit card, the banks, when they give you loans, they're not gonna only look at your report. They're gonna look at other things. Might be your zip code, might be your neighborhood, right? Might be your educational background. That will create barriers for low-income patients. So my point is, remember, policymakers are human beings. They have limited knowledge and they have imperfect incentive. In many cases, as I said about the COVID-19 testing, the government officials are connected with the test companies, and they have imperfect incentives. All right, so these rules always hold. I'm trained as an accountant, so my view is really based on economics literature. So these rules are rooted in human nature, and they govern every transaction and every participant on the market. Nobody really can escape from this. I heard my students said, how about churches, right? They're purely, spiritual. But guess what? Church need money, right? If you don't send money to them, they would love it, and they need money to survive. So these rules governs all transactions and participants. When these rules are ignored, you might not see immediate consequences. However, the markets will always find ways to retaliate, harming individual and society interest. So I won't really spend time here listing all the examples, but if we focus on even in healthcare, we should have pretty deep understanding of how the market will come back to us. And then I put a link to a related article. So that's the first part of my talk today. It's really a fundamental rules of money. Second, let's look at the evidence on price, access, and health. So all this, I bet you're pretty familiar with this, our life expectancy versus developed countries. We have a lot of expenditure, right? We're on the x-axis, we have a lot of expenditure, but then our life expectancy is pretty low. And then you won't be surprised to know that how wealthy US citizens are pretty comparable to other countries. So who's really dragging behind, dragging this life expectancy? Low income minority, right? Marginalized citizen. They really have a huge gap. And they are not getting what they deserve in terms of healthcare and outcomes in the United States, although we are a developed country. And look at the price. This is the comparison between healthcare products and services versus other things. As you can see, hospital services is the highest, right? And then tuition fee follows, and then Medicare, medical care services, etc. But then the things on the bottom that having lower and lower prices, unsurprisingly, are facing little government intervention, little subsidies, little intervention, let them compete, and then all the things are red, as you can imagine, education, higher education, and healthcare, where we have a lot of government intervention. So the competition, competitive force did not really work very well. Well, that's one interpretation, at least. All right. And then we also have insurance restricted access, right? So we spend so much money and we're not really living that longer. And then in commercial, if you pay attention to the news, you must know that we have more and more medical debt, right? We have high deductible plan, which was not really a thing if you go back to maybe 10 years ago. Then people are saying premiums gonna be higher. It's almost like daily premiums higher, drugs or medical service, everything. And then Medicaid and Medicare. See, the Medicaid patients and the Medicare patients right now, they don't really have control of their money. They don't have like a HSA account, health savings account. In my opinion, they are really facing this kind of price discrimination. Like they don't have their money, cash, so they cannot access some providers who refuse to take Medicare, Medicaid patients. And there are many such providers. And also, more fundamentally, if I'm a Medicaid patient, I decide I'm going to work out, I'm going to eat healthy, I try all I can to be healthier. I don't get any reward. Do I? There's no reward, zero reward for me. I'm really saving money for the government, but personally, I get no direct reward. Right? It's not like, okay, I become healthier, I got some cash in my pocket. No. So that creates a terrible incentive, right? If we are all, privately insured, so if we have a high deductible plan, we should feel pretty deep on this, right? High deductible, let's say $5,000. If we become healthier, we try to do a lot of preventive things. We might not use much, and then we enjoy lower premium. So there's a direct link for what we do versus what we get. But in Medicare, Medicaid, you don't have that. These patients don't get any reward for their health enhancing activities. And then we have unsatisfied providers. Activity restrictions, you think about providers, we have administrative burden, we hear this burnout all the time. And this is study on the right hand, this is a study we did in JAMA, published last year in JAMA, is looking at hospitals. This is only one part of the burnout. It's about the quality reporting. Quality reporting, they have spent like a lot of money, more than $5 million from just Johns Hopkins. It's everywhere. You have to do a lot of reporting, and you use physicians very limited valuable time to do that, and they're not happy. And then the innovation restrictions. So think about the innovation. So if you are an insulin provider, right, insulin or any common disease, you have this great way to reduce the price, and then you can reduce it maybe until from $100 to $50. But now the government says, you know what? There's a price cap. Nobody's gonna pay more than $30. Make it up. Nobody's gonna pay more than $30. That will immediately kill any innovative effort to reduce price. It's just like tomorrow, all your grocery shopping is gonna be covered. All your grocery shopping is gonna be covered. You only pay like $5 a month, let's say. Then you can imagine there's no reason for the producers to give you more variety or lower price, because you would not care, right? It's all capped. So that really kills innovative effort to not only producing new things, but also to bring down the price. All the innovations actually bring down price. If you think about it, right? TV, computer, etc. The innovation bring down cost, bring down price. But that's not going to happen in healthcare if we really have the cap, because nobody cares. Nobody will care. So in reality, I hope you will agree with me that for the past decade or 2 decades, we really have higher and higher monetary input. We're spending more and more. But then we have suboptimal health output. What I mean is life expectancy, satisfaction, right? Everybody is not, very few people are happy, let's put it that way. Many people are unhappy with the system. Now, who to blame, right? There are different opinions, great or bad players. But to me, I think the root cause is policy failure. We have a huge policy failure. So I'll give you some examples. Look at the physician. Okay, so HCA restricts physician-owned hospitals. as a horse trading during ACA negotiation. At that time, ACA need to pass, they really need hospital association to support it. And hospital says, you know what, if you want to, those are big hospitals, by the way. If you want us to support ACA, you must include the provision restricting physician-owned hospitals. That's how it becomes law. It became law. Ever since then, no new physician-owned hospital can be established, and no expansion is allowed. Okay, that's ACA restriction on physician-owned hospital. Then we have certificates of needs law, and then Stark law, site-based payment. Like if a physician office, I provide some colonoscopies, let's say $200. But if you go to the hospital-owned facility, government will just pay more than that. Actually, we the study, it's a pretty big gap. Even the same service, different site. So and dual fee schedule is also limiting cash price transparency. So the legislative regulatory environment create a uneven or unleveled playing field, supporting incumbents, supporting large hospitals, and really making it hard for physicians. And then we have all the link on the right side. Then the result is, look at the medical office square feet being sold. It's really skyrocketing, right, from 2022. So for the path from 2015 2022, and then we have more and more physician employment by large entities. So you might say that's because of the large entities are greedy, but physicians have to be voluntarily willing to be sold, right? And why is that? It's because the environment is very hard for physicians to survive. And come back to my point of policy failures. Then look at the drugs, right? We all know 340B drugs, right? 340B drug pricing. And then hospitals actually, whoever enjoys 340B are actually charged, have a higher markup for private payers. So you can take a look at this on New England Journal of Medicine. And then PBM, we all know PBM is also a hot topic. One of the major issues of PBMs, if you're familiar with that field, is PBMs they like high list price, high rebate drugs. And then patients pay based on list price, some kind of cost sharing. Then if the rebate is very high, meaning that the gross price and net price has a big gap, guess what? Patients gonna pay more than their fair share for the cost sharing, right? Because patients pay based on gross price. Then we have this weird, the sick subsidizing the healthy. Well, this has invited a lot of criticism, saying PBMs are really greedy. But then let's look at back. Who allowed PBMs to take the rebate? It's a safe harbor. Congress enacted safe harbor for PBMs. So it's not market, right? So you just take away the safe harbor, it will be solved. But no, they're still there. So that's again my point. These kind of situations are purely consequences of policy failures. Then premium example. So after the passage of IRA, IRA just 2022 passed. So the Medicare Part D average premium jumped 21% from 23 to 24, 21%. But for the past 13 years, it's only 9.2%. So it's a huge distance. So before IRA is 9.2% for like 13 years. Remember, this is actually lower than inflation. It's growth increase. But then in 1 year period of time, it already jumped 21%. It's much higher than inflation. What happened? Simply because Medicare Part D has this, mainly because it has a cap, out-of-pocket cap. Then you have to pay. There's no free lunch. That's why the premium goes up. And the same thing with ACA, right? ACA, they before 2 years before ACA implemented, it's about 6% increase in premium. But after ACA, it's 39% increase. So again, it's because of restrictions on what the insurance company can do. On the surface, really help the patients, some patients, but then the big issue is really the premium increase and then price increase because of consolidation. So this, the government centered so far, the policy is really focused on government intervention. If the price is high, we try to do some regulation. But guess what? Whoever involved in regulatory process are usually very powerful players. So they can easily capture that process to use regulation as a way to fend off competitors. That's why we're gonna see price increase. So this is my summary of the government-centered policy pattern for the past, I would say 1 to 2 decades. So we want to protect consumers, right? We want to protect patients. So we detach patients from their money, right? We detach patients don't really control their money. Like, let's say Medicaid patients, you don't need to worry about that. We are gonna subsidize you, but you don't really see your money. We arrange everything. So detach consumer from money. Then we expand public dollars. So basically, we take more. We either take more debt or take more tax revenue, and we expand the public money into this. And then this whole process invite crony capitalism, as the COVID-19 testing. If you think about Epic, if you think about the certificate of needs law or physician in the hospital, everywhere, right? If you have more regulations in this realm, inevitably the more powerful, more connected players gonna get involved and capture the process and have regulations helping them, not necessarily helping patients, and always limiting competition. And then guess what? The price will definitely rise. The price will definitely rise. There's no way the price does not rise. A simple example, you just give insurance company so much power. How can you imagine insurance company afford to say, oh, the medical spending dropped, so the premium will drop? No, that will hurt their revenue. They would never do that, right? So there's no way the price can go down. So keep going up. And then people will blame greed. People will say, this is terrible. We did so much to control price, but still price go up. So this must be private sector greed. So let's keep detaching consumers from their dollars. Let's keep intervening. Then we keep going this cycle. We can see higher and higher price, and then lower and lower outcome. So we are facing. Why do we? I think this is the important timing for us to talk about this. We are facing huge opportunities. Think about AI, right? It's really changing how people do things everywhere. It's also changing things in the medical healthcare realm. It's really unprecedented opportunities. And that also means we have a huge opportunity cost, meaning that if we do not do the right thing, we are failing our patients. We're failing our physicians. We're failing all the stakeholders in this sector. Okay, huge opportunity cost. At the end of the day, remember, patients only have one, everybody has only one life, right? If we can make things better, the value is just invaluable. It cannot be measured because people can live longer, keep happier, and we can have more innovation and more human development, and then we have a better economy that can lift many people out of poverty. So next text I will talk about, who should take more control. So we already laid out that the government taking a lot of control. It really did not give us optimal outcome. Then who should take more control? I believe it's patient. You might think should be, many people might think it should be physicians, but I think fundamentally has to be patient. Nobody really cares about yourself more than yourself, basically. You cannot delegate this to other people. You can't, because other people are not 100% aligned with your interests. Even your spouse, even your children, you name it. Only yourself will care about yourself the most. And then in healthcare, all the other players taking healthcare as business. Only patients take healthcare as their life, right? So let's look at the social determinants of health. Why do I bring this up? We did a study, so this feel free to find the article. We have links. Money and love are the primary social determinants of health. I know a lot of our audience here, people here in the audience are interested in social determinants of health. Studies show only 10% of mortality variation is explained by healthcare. 90% actually not explained by healthcare per se. It's really by your social, by your habit, by your other things, the social determinant of health, basically. So in order for us to be healthy, healthcare is too late, right? We need to have that motivation, try to be healthy in the first place. So, and money and love have been identified as a primary social determinant of health. In other words, if you have more money, you'll be healthier. If you have more love, the love like social connections, right? You have good relationships, you're more likely to be healthy, be loved. Yeah. And this has nothing to do with healthcare. And then human capital development is such a key issue linked to social determinant of health. Why rich people live longer? Why rich people healthier? It's not only like their healthcare access, but also fundamentally they have developed some skills to do self-discipline. So unless that's what I wrote here, unless we are incapacitated, when we gain control of our money, we examine our needs and make resource allocation decisions, take actions to achieve our goals. So this whole process requires human effort. So then we develop many skills, gain familiarity with money, build confidence, accrue lifelong benefits, crucial for lifting us out of poverty and leading a productive life. Why is this? It's about Medicaid. Okay, so giving Medicaid patients a safety net and then give them cash, in my opinion, is much better than here's arrangement, take it. You have no power, you have no choice, just take it. In that process, patients really get nothing. They get nothing, and they have no incentive to develop their health in order to get more money to their bank and then use for other purposes. So I think that's really fitting our patients. So the human capital development and social determinant health are very important aspects, should not be ignored. The moral hazard of self-insurance. The blue things, what I think we should invade, we should dare to invade it. We have personal control that will promote intrinsic motivation. Like, I have personal control of my money. I want to be healthier. Then I make more money. Then I control more money. And then that will be the most important insurance we ever have, self-insurance. So then we have better health for sure. Then that can give us health equity. Health equity is not being granted by other people. Just say, we arrange everything, it's always unequal. It's always unequal because you're gonna have access to different providers than me, right? We never get equal. However, if everybody have this intrinsic motivation and create this motivation and desire and have control, we will really have health equity. In contrast, this to me is the dead end, the yellow thing. We have no personal control and we are being taken care of. There's no motivation for us to be healthier. And there's no motivation for providers to deliver lower price healthcare or helping patients, right? Everything's overarranged. Why would you, think about yourself dealing with Medicaid patients 100%, and then the government pays you exactly what's the motivation there for you to do better? And then that will lead to human capital atrophy, right? You don't need to think. Everything's arranged. That will actually create health inequity. Because some people gonna access everything, and you cannot. You're only accessing the things that you are told to. So this is what I'm worried about. Moral hazard, right? It's about your effort. We have to make patients willing to improve their health, willing to look around and having control of their life and their money. That's eventually the way to better health. So, finally, the last part is really my opinion, this core idea, patient-centered healthcare. We should get away from government-controlled healthcare, but more go to a patient-centered healthcare. So getting the core ideas, just getting people closer to their money. So we wrote the article on general medicine, health insurance coverage broader always better? No. So if you have more broad healthcare insurance, you take away patients' control of money, and then actually does not really bring better health. So in my opinion, there are three prongs, right? First of all, we must have a stop-loss safety net. The safety net is extremely important. Government should have subsidized the safety net, so like stop loss, nobody's gonna spend more than that. Everything's like covered at stop loss. And then we should have flexible essential plans, and which flexible HSAs, health savings account. So let me repeat, you have the stop loss to help the patients, low income and high risk. Okay, if you get cancer, don't worry, stop loss insurance takes care of it. Then you have flexible essential plans. Like if let's say I'm 60-year-old, I don't need any like maternity care or abortion because I'm a 60-year-old. Then I don't need a lot of, for young people. I can just have my flexible essential plans, like really tailoring to my need, almost like you do auto insurance or property insurance. Those kind of plans will be much cheaper because it does not cover everything, right? Really tailored to patient need. And then you have lower premium, then you have more money in your HSA. HSA, by the way, is triple tax benefit, right? Triple tax benefit. Then you put the money there, and you compare shop and you save. And then you liberate physicians, let physicians compete. At the end of the day, physicians are providers of service, right? Not the administrator, not the MBAs. And patients and receivers, we want to make patients and the physicians as close as possible. Right? We don't want so many middle people in between because they're going to take your money away. So we liberate physicians, let them get close to patients, and then we provide a very solid safety net for patients, and then we give everybody flexibility. Guess what? That will be, in my opinion, more equal healthcare system. So the only pathway, as you can see, how much lobbying money goes there. This cycle extremely hard to break. Extremely hard to break. We are facing huge amount of political and industry interest. Can you imagine what the insurance company would say, right? Can you imagine what hospital industry would say if you look at what we're seeing there? That's really hurt their benefit. But the only way to break this is creating constituencies among our patients. When patients really get control of their money, they will do many magical things. They will improve their health, they will comparison shopping, they will see price go down, and guess what? Providers will compete to meet the patient's need. Right now, we do a price transparency, but guess what? If you go to any plastic surgery website, because plastic surgery is not covered by insurance, you will see the best, the most transparent pricing. Or if you want to go to some AIC, ambulatory surgical centers dealing with cash pay patients, they actually put the picture on their website, your shoulder, knee, hip replacement, and then bundle price. Just in case you don't really read, you know the picture. And they give the price covering everything, including your pre-care, pre-surgery, infection, your prevention, post-care, anesthesiology, everything. Because that's the easiest for patients. Did the government ask them to do that? No, government did not ask them to do that. It's purely voluntary. The providers will innovate, try to meet the need of patients. So that's why I think the only way to break this cycle is giving patients more control, especially our low-income patients. And then we have a new cycle, right? Once we have more and more constituencies, these people do not want their benefit taken away, right? Just like the big players don't want their benefit taken away. So that's how we counter the big interest, big lobbying money. Then the patients, once they have the control, they will see lower price. As we know, like Amazon Pharmacy, if you pay attention to any generic drug space, we're already seeing that happen. Amazon Pharmacy, GoodRx, Mark Cuban, they really make a cut in that space. So now you can get $5 per month. Amazon Pharmacy without the insurance of your generic drugs, most common generic drugs. So the patients, once they see the low price, and then they see, let's say, the direct primary care, you have physicians with a more aligned interest, giving you better care without really invasive, expensive procedures, then you taste it, right? You get all the benefit. So that's what I mean by low price, high quality. And that gives us more equal access, right? We are really reaching there. Everybody have control. Everybody try to improve their health. And then they have equal access. I have money, I'm medicated patients. Guess what? I have same access as you guys. The product will see me. And then you have more relief, the employers. Oh my God, employers, right? They face huge legal risk. With ERASA, they have to provide the best, not best, but affordable care. And then they have limited ways, right? Unless you're super big. So if we have this move to that direction, the employer cannot be relieved because they just give the employees money and the employees can purchase insurance on their own. And then we have motivated innovators, including providers. Providers and then drug companies. If you look at Lilly Direct, right? Lilly Direct's trying to give weight loss drugs to patients who want to pay cash. So those providers will find a way to bring affordability to patients. Not just the new things, but also the old things lower price, as we have witnessed in like PC car industries. So those stakeholders will build the strongest political will that cannot be defeated by any lobbying money. Cannot. Because this is really for the market. People taste it, people do not want to lose their benefit. That's a new cycle. And then the energy. Where's the energy? This is individual, right? Individual players, where's the energy? But the energy actually is immense. It's unlimited energy. In my opinion, this kind of approach really taps into two energy sources. Number one is on the buy side. As consumers, as patients, we have unending desire to pursue cheaper things, better things. That's always true, right? We on the buyer side, we always want the cheaper things, better things. Even if it's already cheaper, better, we still want the cheaper, better. That is the extremely important force to push innovation, push economy growth. On the sell side, provider side, including insurance, including PBMs, they want to make money, right? As we laid out at first. They want to make money. So in order to make money, they must make consumers happy unless their revenue source come from them. If their revenue comes from the public, from consumers, in order to make money, which they really want to make money, they will have to innovate, produce things that consumers want, then to meet their desire to buy cheaper, buy better. And then those two, buy side and the sell side, this unending, extremely strong desire to buy cheaper, buy cheaper, buy better, and then innovate to make money will push us to a better scenario, better outcome. So that's to summarize this kind of two energy sources. So if we dare to give patients more personal control and a solid safety net, that will be much efficient than what we're doing right now. Because our money right now is a lot of going to middlemen, going to really nothing to do with healthcare. And then we will have so much more money to spend on safety net and give people personal control. That will really lead us to affordability, equality, and health. Not just health insurance, but actual health, live better life. Okay, so that concludes, and thank you very much. Sorry, I did with 5 minutes over, but I'll be very happy to take questions. Thank you so much for bearing with me.
No problem. I see you have your hand raised, June.
Yeah, can you hear me? I'm on a headset.
Yes.
Okay, great. I might have missed this part, but I wanted just to clarify, the issue that you referenced starts with patients being detached from their money. And I know that you said price transparency is a way to combat that, but it's this bridge that I'm looking for. What is the bridge between where we are right now in terms of the third party paying for everything and getting to the point where patients are price shopping?
Yeah, great question. So actually pretty straightforward. Let's say I'm going to start with employer side, right? Employer now have our option to do the HRA, health reimbursement arrangement. So HRA, health reimbursement arrangement. So just saying, allowing employers to give money, chunk of money to patient, let the employees to buy insurance by themselves. If our individual market is flexible. Right now, they're not flexible because the plans have to comply to all the ACA regulation. That's why the premium is so high. The premium of individual market is so high. Let's say there's some loosened regulatory environment. The premiums affordable. Then guess what? Individuals just buy insurance on their own at their local market. A big problem facing employer is that their workforce is very much dispersed. Right, Joe? I think I'm big. I'm Amazon. Guess what? Many of my employees are everywhere, like dispersed everywhere around the country. At the local level, I don't have purchasing power. My employees work together, even combined together, are not really a meaningful patient population for a large hospital. It's nothing. Therefore, employers really don't have much negotiating power on most markets. But if you let people buy insurance at the local market, things will be totally different. Because people buy the local market, the insurance really for the local market, the insurance can have extremely strong market power. And that is the way, right? Patients will buy those insurance, and then they have a chunk of money, put that into HSA, then they will definitely comparison shop. Yeah.
The reason I was asking this question is because prior to, yes, government policy plays a role, but actually, I think the biggest factor detaching patients from their money is the whole concept of health insurance in general,
Exactly.
right?
Totally agree.
Before before our current model, we had an indemnity model where you pay the doctor and then you submit a claim to the insurance company and the insurance company pays you, and therefore you know the price. But I mean, what you're talking about here is changing how we get insurance, when I think the bigger issue is this price transparency that, or lack of transparency, that is the result of health insurance in general, right? And so there's this fundamental, I don't know, problem. How do you get price transparency when the whole purpose of insurance is to cover things that you can't pay for? And yet the way you get transparency is via an indemnity model that you can't really pay for. Right?
Good point. I want to just quickly follow up on Julie's point. Our goal for the past 2 decades have been broaden insurance as much as possible. Let insurance cover everything. But think about fundamentally, should we ask insurance cover everything? If you go to car insurance, let's say, gee, I'm going to have a buy insurance tomorrow, auto insurance. I'm going to cover oil change, wiper replacement, everything. You know what? My insurance plan will be priced out of market. Nobody want to buy my insurance. Nobody. Because why? Premiums too expensive. People want to have an insurance only covering bigger things. So small things, they can just pay back cash. That will actually reduce the price, right, for the small things. That's what we wrote in the jump into medicine piece. Generic drugs, like shopable things, should be picked out of insurance. If you look at GoodRx, the price you pay GoodRx actually can be lower than your out-of-pocket spending for generic drugs. Why? Generic drugs so cheap. If you go through complex insurance, you add so much admin complexity, so you end up paying a higher out-of-pocket. But these things should all go to cash pay, complete cash pay. Therefore, our premise of broaden insurance, having insurance cover more and more, in my opinion, actually is a captured result from there's some political and insurance interest and provider interest. It's the outcome of that. It's not really serving patients well.
Listen, I see you have your hand raised.
I think it's Dr. Perkison.
Hi. Yeah, thanks for a great talk. I'm a provider myself in both primary care and occupational medicine, so like the liberate the physicians part of it. The issues I see is, I think it makes a lot of sense. I think using a model for reducing people's healthcare coverage really works well when you're talking about insurance premiums and providing them a service for that. But I think one of the discussions is, well, really is determining what does that safety net look like? How deep is that safety net? Because there's a number of different things that we touched on, the skewed difference in healthcare costs between the young and the old. And basically there's a sense that younger consumers are going to help pay for those numerous costs that really occur at the end of life. The other thing is social determinants of health that you mentioned, is that in addition to costs, there's also numerous other things that are inhibiting to access good healthcare, like transportation, access to healthy nutrition, a lot of things that aren't controlled just simply in the economic model. And then lastly, the issue with the cost and determining how innovation will bring down the costs. I'd like to think that, and I'm sure that happens in some models, but the other thing is, if you look back in the 1970s, when we simply had a fee for service charging, and there were no caps on what those fees for service, there was a tendency for those fees to go up, and there were no caps, and physicians charged a lot. And so I think on their own, given the sort of the laissez-faire approach to it, I'm concerned that really physicians do need, and healthcare systems need caps. They need someone to control those costs, because the tendency would be for higher costs rather than for lower costs. Sometimes innovation in healthcare doesn't work that way, just because healthcare is such a unique consumer item. It's based on, it's an essential need, but it's also based on perceptions of the public that's much different than a simple product, as Srila had mentioned in the chat. It's an essential need. So thank you.
Yeah, thank you, Dr. Perkison. This is great comments. Let me First, I believe, if I'm from business school, I believe the best antidote to grade is grade itself. If you look at the TV, car, there's no government control, but why price go down? Because nobody can afford to price out of market, right? If I go up, let's say fee for service, at that time, there's also some kind of detachment, right, going on. If there's no detachment, let's say if we all imagine primary care is out of insurance tomorrow, everybody's having their HSA, then no, in my opinion, no primary care physician would dare to have a high price and then keep referring patients to expensive services, because patients will get duped once, they won't dupe twice. The words will spread. Again, this is for shopable service, not expensive, like complicated services. So I think once the competition is there, all the greedy players fighting each other will be the most effective way to limit grade, to limit by self dealings. And then the wealth, this is a great point. The HSA's whole idea is like people's wealth also increase as time goes by, right? So you want people to have this view of saving the HSA, investing in HSA, and then eventually use more HSA. But also they want to also purchase more expensive insurance, right? As you self-selection issue. And then that go back to your social determinant of health. How can we build this safety net? In my opinion, just government-funded stop loss. Because the people who got sick, really big problem, they're really not under control, right? I got cancer, that is fundamentally government job, our taxpayers' job. I don't think taxpayers will have any problem supporting high-risk individuals, but taxpayers have a huge problem supporting middleman complexities and sending money to the people who have absolutely no relationship with healthcare. So that's my view. And then the social determinant health. I really believe the social determinant health is so complex. Not a single person beyond the patient will have a bad idea. A physician will have the best idea in terms of beyond the patient. But fundamentally, patients really have the best knowledge, unless the patient have some serious health issues they cannot control, they cannot decide. Therefore, I think this thing should be left to patients and their providers. I mean, physicians. They should discuss and decide how to use the pot of money. Should not be government saying, oh, we're going to put this chunk of money to your transportation. You use it or lose it. That's not okay, because we want the money to go to the patient. And then let's say Dr. Perkson says, you need healthy food. Then I use the money to buy healthy food. So in my opinion, that would be the better system. Thank you so much, Doctor.
Yes.
Thank you.
Thank you so much. It marks the hour. But it's been a great engaging session. I'm sorry, Carey, that we didn't get to your question. But yes, I just encourage everyone. We'll post this up on our YouTube channel and on the Mighty Networks page with the slide deck that Dr. Bai agreed to share. So again, thank you so much, Dr. Bai. It's been a great session, and I hope everyone has a great Thursday.
Thank you so much. I put my email address there. I would love to continue the conversation. Thank you very much, given the honor.
Absolutely.
Bye.
Thank you.
Thank you.